Okay, welcome to the podcast of the Black Working Group, where we will be sharing articles of interest alongside their main author. I am Juan Martín Núñez Silveira. I am from Argentina. I am a respiratory therapist. The study of today is titled Magnitude of Synchronous and Desynchronous Inspiratory Efforts During Mechanical Ventilation, a Novel Method. Was published in the American Respiratory Critical Medicine. It's a pleasure for me to have you all here today. Would you like to introduce yourself?
Okay, thank you, Juan Martín. My name is Irene Telias. I'm an internist and intensivist, born and raised in Argentina, also in Buenos Aires. And I've been working in Toronto, Canada for like 7 years now, finishing my PhD in applied respiratory physiology with a special interest in patient-ventilator interactions.
I am Matias Madorno. I am an engineer, and I am also from Argentina, and I live here. I've been developing medical devices for 20 years now, and almost most of it related to respiration monitoring.
Thank you. So I'm Laurent Brochard. I'm a clinician intensivist in Toronto, and I'm a scientist, and I have a relatively large research program, which is mostly clinical and preclinical about acute respiratory failure, mechanical ventilation, and patient ventilator interaction. And I'm also one of the leaders of the Plug group, so very happy to be part of this podcast. Thank you.
Okay, thank you all. Well, we can start. Irene, can you describe briefly the study overall and the main results?
Yeah, absolutely. So it was a very challenging study, and the overall aim was to develop and validate a novel method to be able to, one, detect the presence of inspiratory effort regardless of the fact that that effort was synchronous or desynchronous, the mode of ventilation, and automatically based on respiratory recordings, including esophageal pressure. So once we wanted to detect the presence of an effort, then be able to classify the effort as synchronous and desynchronous, and ultimately, and most importantly, to quantify the magnitude of inspiratory effort. And additionally, then also, since we had the information, to analyze the physiological consequences of inspiratory effort, mainly to the lung, but also potentially to the diaphragm by evaluating the presence of eccentric contractions. Yeah, so that was the main aim of the study and the specific objectives that we accomplished. And the way we did it was by using a very, very large database of respiratory recordings with breathing efforts coming from different physiological studies. We used 3 physiological studies, one on patients with acute hypoxemic respiratory failure, a data set with patients after a cardiac surgery undergoing a spontaneous breathing trial, and healthy subjects. And we really wanted to have a huge variety of magnitude of effort and morphology of effort given different breathing patterns. So we used this huge data set. We organized it based on what mode of ventilation the patients were on, the type of efforts, etc. And then we randomly selected a sample from this huge database to have a representative sample and harmonious sample of different types of efforts. And this was our derivation data set. Some experts labeled each of the breaths into the type of breath that breath was, so synchronous or desynchronous or reverse triggering, without breath stacking, with breath stacking, and ineffective efforts. And then, based on our knowledge of how to recognize asynchronous, based on the airway, on the respiratory recording, we defined an algorithm where we first construct something called muscular pressure. So what's the muscular pressure? The muscular pressure is the pressure generated by the respiratory muscles. And mathematically, the way we calculate it is as follows. The rationale is that whenever we inflate the respiratory system, the chest wall moves away from its resting position, okay? And therefore, the chest wall itself wants to come back to its resting position. And that generates a positive pressure in the pleural space, which we can measure with the esophageal pressure. That's normal in passive conditions when we insufflate the thorax. When the patients make an inspiratory effort, they contract the respiratory muscles, and also they displace the chest wall from its resting position, but by generating a negative pressure within the pleural space. So the difference between what the pleural pressure would have been if that respiratory system was insufflated in passive conditions versus the measured pleural pressure when we take a breath, that difference is the muscular pressure. And when we calculate that parameter and we plot it over time, the presence of an inspiratory effort becomes very evident. So we detected automatically the presence of an inspiratory effort based on that. And then it was very simple. We just correlated the timing of inspiratory effort, so the start and the end, based on the deformation of the muscular pressure recording, to the timing of the respiratory cycle based on flow. So insufflation, the flow is positive, and exhalation is negative. If both coincide, then it was a synchronous effort. And if the effort started before the insufflation, then it was triggered by the patient. And then if the timing did not coincide, then it was a desynchronous effort. Specifically, we focused on reverse triggering and, most importantly, red stacking. And then we had an independent database, a little bit smaller than the derivation database, where we validated this algorithm and also had very heterogeneous types of breaths so that we could nicely demonstrate that it would work in any condition. So that was that. And then the main results is one is very accurate. The algorithm is able to detect the presence of an effort with an accuracy higher than 95%, and also classify the efforts into different types of events very accurately. And most importantly, once we had this identification of the effort, we were able to quantify the magnitude of the effort, which I believe is quite unique as compared to other techniques used to identify patient ventilator dyssynchronies. And we also validated that the quantification of the effort was accurate, the bias, as compared to a regular technique to measure inspiratory effort manually. And based on the usual time references for quantifying the effort, was also, the bias was very small. So it means that the measurement was actually accurate. So bottom line, we developed an automated algorithm for effort detection and classification into synchronous and asynchronous events. And then we went on and quantified the magnitude of the effort associated with these events. And the final thing that we did regarding the results, it was the quantification of the effort based on the different types of breaths. So if the effort was, if the respiratory cycle was patient triggered, or if it was reverse triggering without breath stacking and with breath stacking. And the main results of that are the following. So one, reverse triggering without breath stacking has an effort very similar to the effort that the healthy subjects perform at rest. That's the first result regarding the effort quantification. The second one is that every time you have breath stacking, or in most cases with breath stacking, the magnitude of the effort is higher than the magnitude of the effort without breath stacking. So that turns on an alarm saying, okay, it's not only that the patient has a higher tidal volume, also the effort that they are doing is actually high. And then the last thing was very interesting and really requires further exploration, is that patients trigger events on assist control modes, so volume control and pressure control, are quite high, both per breath and per minute, and therefore, again, it prompts attention and further investigation as of why and how we can help the patients maybe have an effort closer to the normal effort and avoid potentially injurious consequences. So sorry for the length, but I kind of gave an overview of the study and the main results.
Okay, that's wonderful. Thank you. Matias, can you describe the challenge of the algorithm and whether this could be implemented anywhere?
Sure. The challenges was first to detect the patient's effort independently from the flow and airway pressure signals. When we analyze respiratory signals, we usually start with flow to determine if the patient is inspiration or expiration and analyze all the breath. But what defines the breath is the flow. And here we wanted to understand what the patient is doing independent from what the ventilation was doing. So we wanted to detect the patient's effort independently of the other signals. So based on the muscular pressure, as Irene just explained, we calculated the muscular pressure of the patient, and over that signal, we had to detect the patient's effort independently of the other factors. One of the first challenges was related to cardiac artifact, as muscular pressure is based on esophageal pressure. Some patient has some quite significant cardiac artifact, and if the patient has a small effort, it's a small way we have to detect within some quite big cardiac noise. So to be able to find an algorithm that was able to detect the patient's effort and not to detect a cardiac artifact as an effort, and to avoid missing effort because it could be confused with an artifact was a quite nice challenge. And based on we developed the algorithm, and then we analyzing the shape of how the waveform is changing, and then we determined the thresholds to find these points based on the data. We had many breaths that were already identified, so we made algorithmic search in order to find, with all this data, which are the best thresholds that will make the most true positive and true negative detections. And once we detected the effort as a whole, we make a more detailed analysis to find the start of the effort, the end of the effort, and then relating that to a more standard analysis of flow, we can compare if what was happening by flow, where the patient was in inspiration or expiration, has a relation with the effort that the patient was doing. And then we did a nice decision tree based on different factors in order to decide why it's sort of asynchrony. So there were several times that we did several iterations in order to find a nice way to classify the different asynchronies. And we might find the same asynchrony that we kind of detected by different routes in the same decision tree. So it depends on what condition we're given, it will define that says some sort of asynchrony. But if those conditions were not completely there, by some other combination of other factors, we can get to the same asynchrony from the analysis of the signals. It was a really nice project.
Okay. And Mati, the other question he asked, Corey, is: do you think that this could be implemented in real time?
Yes. Sorry, it's an important part. Yes, the idea was when we developed the algorithm was we were thinking the possibility of making all this analysis on the bedside, and yes, it's possible. It might be a few seconds late because we need a lot of information from the breath, but having it 2 breaths delay in this kind of things is the same as real time. So yes, and what we're working now is, if with my other hat, not as a scientist, but as a developer, is to add this algorithm to our device.
Okay. Okay, thank you, Matias. It's amazing work you do. Dr. Brochard, can you explain us the importance of this type of monitoring in general?
Yeah, thank you. That's a key question. I would just add to Matias' response before that I was thinking we may have now maybe 4 recent ICU ventilators on the market which offer to display the signal of esophageal pressure, right? So, I mean, in the future, they could really be interested to have such algorithm and then to display almost in real time, or I mean, sufficiently accurate to help the clinician. So I think, you know, it started a number of years ago because the ventilators started to put screen on their device, and with the screen we've seen the waveforms, and with the waveform we have seen that very often it's not like we expect, and we discovered that very often it was not in synchrony with the patient. So we described this issue of synchrony, and then we tended to say maybe all this asynchrony, this is very bad. And the more we look at this asynchrony, the more we see that in fact there is a large variability between the different types of asynchrony. Some maybe do not matter, some may be terrible, and some may be even helpful to, you know, give additional freedom to the patient or whatever. So you need to have either a very good, astute clinician at the bedside, like an excellent respiratory therapist who is going to stay there the whole time to detect that and make the diagnosis, or to have automated methods, right? So for sure, the situation where we are now is that we want to make people aware that this exists, it's complicated, it needs a specific diagnosis and management. But in the future, we will need automated recognition. I think what Irene described about the breast hacking is a good example. So breast hacking is relatively easy to recognize. It may be from different mechanism, double triggering because the patient has high drive, or reverse triggering, but it's characterized by relatively high effort. So that's that tells the clinician that you should avoid it. But there are many situations where it's complicated. You need to make calculations. So I think to have a much better fine tuning of the ventilator to make the patient more comfortable, hopefully use less sedation and have better outcome. This is the way to go to monitor this type of synchronous or desynchronous effort, have an idea of the magnitude of the effort, and have a mechanism which allows to manage the ventilator in a way or another, or decide to go for sedation or even paralysis in some time.
Okay, thank you, doctor. I want to ask you, what about the role of the plaque group?
Well, you know, if you look at publications in the field of respiratory physiology, we made very important discovery in the past, like the auto-PEEP effect, which was described in 3 patients. But the more we see of the complexity, the more we realize that we need to have collaboration. And to collaboration for different reasons. One is to discuss all together, because these are really complex, and no one has always the truth, so it needs different perspective. And also to do physiological research like we do multi-center trials. So with, for instance, physiological recordings from many different places. So the plug group is trying to maintain the best possible quality for respiratory physiology at the bedside, to attract the people interested by that, and to foster collaboration between people and across the world, because now it's easy to discuss between Buenos Aires and Toronto, to take an example, but we have people in the plug from every place in the world.
Okay.
And I wanted to, add something to that. Actually, this study, and it's not only the study itself, but it's this development, wouldn't have been ever done if the plug didn't exist. Like, we have a huge database of respiratory recordings with esophageal pressure with an excellent quality, and that allows us to do this type of recordings, hoping that in some patients, some days, we wouldn't even need the esophageal pressure, but without going through this pathway and having this huge collaboration, we would have never developed this huge database that will allow us to, for now, developing these new tools, but tomorrow, and we're working on that, having a concrete answer of what's the meaning of these events and how to manage them. So I like we really thank the leads of the group and remember Shorty with our heart that you decided to go into this big collaborative endeavor.
Okay, thank you.
And we also, sorry, Juan Martin, we also want to make this database available to researchers, physician, engineer, respiratory therapists interested by the topic. So just to make progress in our knowledge, right?
Okay. Thank you both. Matias and Irene, what do you think about the following steps?
Well, Matias, I think maybe you can expand on that. He mentioned a little bit about the integration into the automatic recognition at the bedside, and Laurent added the possibility of incorporating it on mechanical ventilators directly. From my side, the next step is to actually analyze this big database. It's a prospective cohort study, the VR study, that aims at understanding the incidence, determinants, and clinical consequences of this breathing effort, whatever the type, synchronous or desynchronous, and therefore starting to have a more real understanding of what's happening at the bedside, and then continue with continuous record. These are just recordings for 20 minutes to 1 hour, 3 times a day, to have a representative sample of what's happening with the patient, but then move on to continuous recordings, understanding which patients we will still need esophageal pressure forever, which I think it will end up being the case, and in which patients we might be able to do this without such tools, or maybe continue developing different types of esophageal probes so that we can use them a little bit more broadly. So I think those are the natural steps. I don't know, Matias, if you have any other insight.
Yeah. Well, the first step is to make it a tool in order to be used, either for processing signals like the other broader database, as Irene is telling, to have it available, or to have it available in a device, either a monitor or a ventilator, to convert this in a tool that can be used more in a clinical environment. And on the other side, then make this to analyze bigger databases, we are working on different. It's not the same to process fragments of signals when we know that the signal is correctly set up. The signal is esophageal pressure signal, for example, is properly insufflated the balloon, and all the technical conditions are provided. And we knew in the fragment that we analyzed for the publication was those fragments were from the technical side were very good. Now, if you're going to use it more in a more general base, it's important to differentiate if the esophageal pressure signal, for example, is properly placed, or a flow sensor is not connected, and detect a lot of anomalies that would normally happen that the algorithm is not expecting to sort out.
And then the last thing is, once we understand these incidents, determinant consequences using observational data, we will have to go on and think of, okay, what's injurious, what's not, what interventions can we do to manage them, and really prove if modifying the ventilator settings and or the sedation, targeting a certain amount of asynchrony or a certain magnitude of breathing efforts during the desynchronous events, it's actually beneficial from the patient for the patient in large RCTs. Mm-hmm.
And we have many additional questions that we or other can address, like is it the same if you use volume control or pressure support or NAVA? What is the influence on the amount of pulmonary edema, etc., which I think make a difference. What happens when you switch from the initial phase of controlled ventilation to spontaneous breathing, etc. So we have a very rich database to address these questions.
Okay, thank you all. Okay, thank you very much for the response. I'm sure these topics will stimulate the future investigations. And do you have any final thoughts you would like to share with us?
Well, I invite people to join the plug. Whoever is interested in this sort of topics, doesn't have to be patient ventilator interactions, anything related to advanced monitoring and applied respiratory and cardiovascular physiology in critically ill patients. Working in a group is awesome, and you get to meet outstanding people that are willing to share their insights on your work. So don't be shy and come and participate. That would be my message.
Even attending to the meetings is really interesting to be present in the discussions.
And don't worry, even if we try to make automated calculation, there will be a need for very good clinician at the bedside for many, many years.
Okay. Once again, thank you for participating in this podcast, and we will see you in the next episode. Thank you.
Thank you.
Thank you.
Thank you very much.